Good afternoon. Welcome to IPC Masterclass Season 3 and Session 4, concluding session of the Season 3. We have today Dr. Sourav Maiti, which is known figure for this group. He was also speaker in previous session. We have Dr. Ranga Reddy, President of IFCAI, and we also have today Mr. Ramdas, who is the Director of Sanmet Healthcare. So to start with, let us give a few minutes to a video by Sanmet, the sponsor, followed by Ramdas will speak to us.
Thank you, Pranav, for playing the video. And a very warm welcome to all the participants for this concluding session of the webinar series on occupational safety for healthcare workers and experience sharing. I think this has been a wonderful series because we are in the midst of the pandemic, and what more topic could have been better than this, because this helps so many of the healthcare professionals to hear from the horse's mouth, the people who are responsible for managing this kind of pandemic, right? So this has been a wonderful thing, and I was just thinking the fact that IPC Masterclass so fast we have covered up 3 series, and today is the last for the third one. We started with epidemiology, with biosafety, and of course now this last webinar for the webinar series, occupational safety for health workers. I think I want to thank Dr. Dhruv Mamota and Dr. Sourav Maiti for this particular subject which they had suggested, and I think also the poll we had last time, where most of you had wanted this particular topic. So, and that there we are, and I think we had a very nice 3 sessions, and today is the concluding session with Dr. Sourav Maiti. I want to thank profusely Dr. Vijay Lakshmi and Dr. Shanta Datta, also very busy people to come and participate and make presentation. Lovely presentation, which was given a very good feedback from the participants themselves. Once again, as I said last time, I want to thank Dr. Ranga Reddy, President in Infection Control Academy of India, for giving the spark to come with a initiative like IPC Masterclass, right? And thanks to the partner University of Hyderabad and IIPH for partnering with particular initiatives. So it's been a collaborative work, and it's really benefited many of the healthcare professionals. As I said in the past, Infection Prevention Control Masterclass is an initiative for helping healthcare workers, right, to deep understanding and knowledge when it comes to infection prevention and control. And the speakers, the quality of the speakers and their experience sharing is priceless. I don't think get it in any of the academic sessions, but but for this practical sessions where people who are in the midst of all this are coming and sharing their experiences, I think. Right? If you have missed some of the sessions, I would suggest that, you should look at, our YouTube channel, because consciously we have ensured that all the webinars are actually recorded and put into the YouTube channel, which gives you an opportunity to once again visit and understand all the sessions which are done. So far, we have done 3 webinar series. Today is the 14th webinar, the session which is there. So 14 rich topic is being put into the YouTube channel, and you can look at it as and when you have time to look at. It's very easy to go for. youtube.com/Sanmed Healthcare is the channel. I think I must focus on this, and I would request you to tell your friends who have not been able to participate in this particular webinar series, right? As you know, and you've seen the video, Sanmed Healthcare, manufacturer of products for infection prevention and control. We have one of the best manufacturing facility, the WHO certified good manufacturing practice certificates which we have. I think the products comes from our quality facility, and quality is the core value we have. And that's where I always say that we differentiate from the crowd of companies who have their in the space. As I said last time, we finished 3 webinar series. We will go on. We will identify what is important topic for in this particular space, and ensure that we contribute adding to this rich bank of knowledge in terms of IPC and infection prevention control. So thank you very much, all of you, and I think we look forward for your feedback. And please do send what you think is an important area to be discussed in the webinar series, so that we can develop along with our core team. Thank you very much, and over to Pranav to carry forward. And all the best, Dr. Sourav, for the concluding session of this particular webinar series, Occupational Safety for Healthcare Workers and Experiential sharing. Thank you very much.
Thank you, Ramdas. I think Sanmed Healthcare has been very kind to help the healthcare professionals at this pandemic time. As Ramdas said, your suggestion and feedback is required to design further program. So today, immediately after the session, the quiz section is on. It is the single link for giving the feedback, giving suggestions, attending the quiz of today's session, as well as giving your personal professional data to prepare the certificates. And this time, certificates will be mailed to you within flat 2 days of time. With this small note, I request Dr. Ranga Reddy, the President of Infection Control Academy of India, to start the proceeding, please.
Let me actually very quickly run you through the objectives of the total series. The objective is basically to ensure that we as healthcare professionals are going to avoid all the hazards which we are facing on the job. Those who have attended the last 3 sessions, you are already aware of those objectives we have set forward for this series called as Occupational Safety for Healthcare Workers during pandemics, and experience sharing by those people who are in the front line, who have done it all, seen it all, and now they came to share it with a wider audience so that all of us can benefit. I had to thank those people who have made their time to share their experiences in the previous last 2 sessions, 3 sessions in fact. That is Dr. Dhruv, Dr. Vijay Lakshmi Nag, and Dr. Shanta Datta. They have set actually the foundation very well, and they have shared some invaluable experience in various settings, starting from the private settings to the public settings, and also looking through the laboratory settings. So that has really made us realize the enormity of the theme, because initially when we started talking about actually sharing the experiences, we thought, what is there much to share? Everything is published, everything is there. But when we got into the details, we understood the enormity of the theme and the subject, and it has really given a lot of insights from the feedback what we have received from all the corners, not only from India, but from at least 14 different countries. Those who have participated, they have said it is one invaluable experience, and this has really helped them to go on with their jobs much more professionally without getting affected by the current pandemic. So now today is going to be, as I told in the beginning itself, is going to be equally interesting. And Dr. Sourav, as usual, a good friend, whom we had many sessions in the past. I'm sure, he will be able to do a great job in terms of his knowledge and his experience with the current pandemic, and deliver us COVID care center and COVID healthcare. That is what is going to be his today's topic. The assessment will come, you had to certainly give that assessment, and you had to immediately do that, so that you don't need to come back asking for your certificates. Automatically it would be happening. Now, a few words about, although all the audience already know about Dr. Sourav Maiti, but let me actually say a few words for those people who are joining for the first time in our sessions. He is an young, dynamic, and academically sound with the technology fluency. Dr. Sourav is currently heading the Department of Infection Prevention and Control at Institute of Neurosciences, Kolkata. As you all know, that it is a premier neuroscience center. He is a CAHO certified trainer. He is a life member of HISI and IAMM. He is the proud mentor for Namaskar Drive. Those who might not know, Namaskar is a drive, which has been introduced as a substitution to shaking the hands, or those people who would like to wish each other as an alternative. He received Quality Council of India Quality Month Award in 2017 and 19. He has extensive experience with neuroinfectious diseases, infection control, leishmaniasis, and cryptococci. He has completed training on online marketing, advanced clinical immunology, etc., etc. I can go on, rendering all the professional qualifications he has, but I rather stop here so that we can have more time listening to his experiences. Dr. Sourav, a very warm welcome once again, and over to you. The floor is yours.
Thank you, sir, and thank you, Mr. Ramdas, also for giving introductions. And today is the last day of our occupational safety related experience sharing in this pandemics. So we were actually living in a very colorful world. Started with Facebook, Twitter, and all the social media accounts. But suddenly, what happened? A monotonous shadow came into our life. We can see here, and I just got a glimpse from the history. The first picture shows that a cholera draped death coming to the US on a British ship. It is a very famous cartoon. And likewise, the COVID also came to many of the countries through airfare. The second picture shows the infamous case of typhoid Mary Mallon, who was an asymptomatic carrier. And we are very fascinated about this asymptomatic carrier also in this pandemic. The third picture shows it's a smoke fumigation of Chinatown of Honolulu. It was done to eradicate plague. And similar thing we are observing now also. We are having fogger machines and fogging everywhere there. And regarding this plague, the Alexander William Kinglake in his famous book Eothen told us that that is also related on plague, that dread of this plague that divided one person from another. And similarly, we are having same experience. Now we are fearful. Maybe with time that fear has decreased bit, but still we are having fear from the person opposite. So the social distancing has been a very effective tool, I would say, and the social nature of mankind has never changed. So we have transformed it in social distancing and social distancing so that our soft skill never get lost. And now we could realize that not the car, not the house or the money can prevent us from this infection, but a prudent step of using mask properly. This was a very important and appealing advertisement from the IRCTC that I found. But similar to the film Diwar, we also need this Diwar, that is the mask, and how it can help. If we see the trajectory of the aerosols and the droplets released after simple exhalation, cough and sneeze, we can see after exhalation it can go up to 1.5 meter. A cough, large droplet can go up to 2 meter, and with a sneeze with a velocity of 50 meter per second, it can reach up to 6 meter. So we are never safe without a mask actually. And the time flies, but never the passion and dedication of the healthcare workers. The same Hippocratic oath, starting at 400 before Christ, drives us from inside to deliver our care to the patients. Only the outfits have changed, we can see, that is according to the time and necessity. And we can see the modern time has changed the patient, physician and illness triad into so much different things. We have the inclusion of the technology, public media, the policies of cost-effective medicine and defensive medicines. And literally, the healthcare worker, every healthcare worker is performing multitasking, and that even compromises his or her safety. Because we can see here, one nurse is handling all those things, handling sharps, handling chemicals, biological substances, paperwork, and all those things. So we all are doing actually all these things. But what about our safety? So the World Health Organization has laid some advisory regarding this healthcare worker rights and responsibilities in this pandemic. So a healthcare worker must be trained, and the employer of the healthcare worker has the responsibility to minimize occupational health risk to the employees. The health worker must have the right to appropriate PPE, appropriate security measures, and most importantly, a blame-free environment. Otherwise, this could not be sustained. And obviously, appropriate working hours with breaks is very much required thing. But unfortunately, I do not know. We are not actually maintaining this. We are not able to, because the workload is so much and the manpower crunch is there. And WHO advocates that healthcare worker has the right to remove themselves from a work situation that they have reasonable justification to believe can present an imminent and serious danger to their life or health. And obviously, WHO advocates strong proposition to that right to compensation, rehabilitation, and curative services if infected with COVID-19 following exposure in the workplace, and access to mental health and counseling resources. Along with this, keeping in mind that healthcare workers must fulfill their responsibilities also. So WHO has reminded us of our responsibility that we have to follow the established procedures, avoid exposing others, and participate in employer-provided training. So it will be a harmonious process. The healthcare worker should treat the patients with respect, compassion, and dignity. And they should swiftly follow established reporting procedures of suspect and confirmed cases, because these two shouldn't be mixed. They have to put on, use, take off, and dispose of personal protective equipment properly so that it cannot spread infection. And they have to self-monitor for signs of illness and has to report. And if required, self-isolation is a responsibility. The government is doing a fabulous work, and regarding the contract tracing, these apps are being used, and this Arogya Setu is doing a fabulous job tracing the contacts. And in West Bengal, we are using another app that is called Sandhane, that means in search. So government is doing actually very good job. And this COVID care, healthcare, to minimize the load, they have divided it into 3 layers of healthcare delivery. First layer is the COVID care center to cater the mild or suspected COVID-19 cases. These can be makeshift facilities like school, auditorium, any hostel, stadium, this kind of thing, or it can be an existing hospital. What is necessary for here is they have to separate the suspected and the confirmed mild cases. They shouldn't be mixed. And they should have an ambulance with oxygen for easy transportation if the case turns from mild to moderate. For the moderate cases, dedicated COVID health centers are there. This can be a full hospital or a separate block of a hospital, and private hospitals can fall into this category. Similarly, COVID care center, they should also be equipped with proper ambulance, because patient here actually will be needing oxygen therapy. So oxygen therapy is a must, and if further deterioration occurs, patient goes into severe condition, or patient in septic shock, and particularly comorbidities will be there, they will be transferred to the dedicated COVID hospital. This can be a full hospital or a part or block of a hospital, and private hospital can be a dedicated COVID hospital. What is requirement is that there should be the intensive care unit, so that they can take care of the shock and the severe cases, particularly the ARDS cases. So this is in a nutshell what are the criteria for determining the mild, moderate, and severe. We can see mild cases, the saturation oxygen should be above 94%. So saturation of oxygen measurement is a very important thing, and the pulse oximeter has to be there. And for people under home quarantine also are monitoring their saturation with the pulse oximeter. And it is very easy to disinfect it by using an alcohol wipe. Similarly, the pulse rate and respiratory rate also determines the severity of the disease. And regarding the comorbid conditions, the certain comorbid conditions are allowed if it is under good clinical control for the COVID care centers. And as per Government of India directive, they can be manned by the Ayush doctors and Ayush personnels. And above that, the allopathic doctors will be responsible for the dedicated COVID health center and dedicated COVID hospitals. So the list is there, the comorbid conditions, particularly if uncontrolled or certain other comorbid condition than covered in the COVID care centers, they would be taken care of. The pregnant women are preferably at the dedicated COVID health centers 4 weeks before expected date of delivery. And Delhi has shown us the way. They have the largest COVID care center of having more than 10,000 bed capacity, and by size wise, it can house 20 football grounds. And that we can see majority are actually the asymptomatic or mild symptomatic cases as of till now. So we require this kind of COVID care centers in large numbers to house them and to monitor them also, because any case can rapidly turn into a severe one. The picture is not coming.
Yeah, it is visible. You have any other picture?
Okay, no, it's not visible to me actually.
Oh,
So if it is visible, then it is probably on the rationing in healthcare. So actually the healthcare system is having the brunt of the overload. So probably the things will come when we would have rationing in healthcare. And with this rationing, what happens? The quality in healthcare actually drops because there will be more insureds, there will be fewer doctors, drugs will get costlier, hospital beds will be fewer, and obviously as a result, less personal care would be taken. So that is a very dreadful situation. Hello?
yeah. Yes, Pranav.
Actually, the slides are not visible on my screen.
No problem. I will continue slide if you can. Right now we are this foundation and pillars page.
Okay. So it is, we will change the slides. I cannot see actually the slides over here.
So
Dr. Sourav, you can open your presentation in your local computer, and then Mr. Pranav can help you actually to roll the slides. We are able to see the slides.
Okay, so I am at slide number 18, foundation and pillars, right?
right.
Okay. So what we are seeing that the foundation is our healthcare system. And who are the pillars? Actually, the doctor, nurses, the paramedical staffs, and the laboratory personnel. We can see. And the patient loads getting increased, and we can see the more we move from the fulcrum, the load is further much more. But more we move from the fulcrum, the force if we apply, then it will be easy to handle the situations. Like the laboratory, if we can strengthen the laboratory services, it will be easy to move the burden. And we can see here that a person with microscope, possibly a microbiologist, is sitting over there who will be doing the diagnosis.
So we are at the pole 1. QR code.
1 minute.
So meantime, this is a poll. What is written in the QR code? The audience is responding. I suggest Dr. Maiti, you can click the slide button, and then you will be able to see the right side of your screen, your slide in your menu. Is it visible now?
No, actually the screen is visible, but it is not showing any content, the slide.
No, just see the button. If you click the slide button.
Yeah.
And, yeah, are you able to see the slide button? No.
The slides button is as lowest part.
Okay, and in that case, what to do? Then I will advance your slide. Only you have to tell me when to advance that, because disconnecting
Okay.
will cause a problem in that case. So I think we'll not take a risk. So response has came. Are you able to see the poll response now?
Mm, yeah.
Okay.
So I think it is still continuing.
Yeah, so I think you can start talking now, because I think most people have responded. 68% people say can't tell, and 27% say COVID-19. Good.
Yeah. So we can see when this unknown scenario comes to us, we may see many things in that, and we may comment also, this looks like this looks like that, but ultimately what is the answer, we can know. So next slide.
Yeah.
So we can see here electron microscopic image of an isolate from the first US case of the COVID-19. We can see here that in a dark and black and white background, there are blue particles with black starding. Anyone can think of anything, but a microbiologist would identify it as a coronavirus, beta coronavirus, that is SARS-CoV-2. So similarly, if when we do not know the picture, what it could be, we may have many imagination and think of that is our perspective also, but we may not be true. So ideal is proper laboratory confirmation of the diagnosis is the required things. Next. So we can see here the SARS-CoV-2 is actually more infectious than our influenza. These are the basic reproduction number. According to that, virus has been screened. Next. So how in my hospital we started? So when the waves of suspected pandemic came, the news came to us. So it was me who told everyone what to be done, what not to be done. So called the initiation of all those things, may be rituals, may not be rituals, and the safety precautions. But somewhere we were having a neuro center, and there is a joke that difference between God and neurosurgeon is that God doesn't think he is a neurosurgeon. And there is one author who also suggested that neurosurgeons would see that as of God's failings. So maybe we were not so much ready, and people were thinking of COVID cannot enter in our secure premises. Next slide. So, on a fine evening, a 65 years male patient with a brain lesion comes to the emergency. He was unconscious for last 3 days and had fever 15 days back. Presently, patient was afebrile, saturation was 98%, Glasgow Coma Scale was 4. He was examined at emergency, admitted, and as a protocol or thing, the chest X-ray or CT scan brain was done. Neurosurgeon examined the patient, and patient suddenly develops respiratory difficulty and was transferred to the intensive therapy unit. And on day 1, patient develops fever. Now, on the suspicion, the next day the COVID-19 RT-PCR test was done, and fortunately or unfortunately, it was positive. So the response is like that. We have contracted a deadly thing. But what we did, we actually screened all those staffs according to the level of exposure. The WHO has advocated a good checklist for the healthcare workers who are exposed to what extent. So at that time, we didn't have access to that manual, But what we saw is our real picture is that one emergency doctor wore just a surgical mask, examined patient, including the Glasgow Coma scale, and took history from the relatives. And as you know, then emergency, there is practically no possible social distancing. So it was just messed up. And one nurse wore a surgical mask and accompanied patient to the ITU, checked the vitals. Radiographer was more concerned with safety and he wore gloves, mask, apron, headgear, performed CT scan. The neurosurgeon wore a mask. We were not sure whether it was N95 or surgical, but he wore a mask but he observed patient from a distance and he saw the CT scan film and the RMO actually examined. The resident medical officer wore N95, gloves, goggles, examined patient chest and the parameters. And one ITU doctor wore N95 mask, gloves, apron, and evaluated patient and also intubated the patient. And following the exposure, we tested all the suspected exposed staffs. And on the first run, what do you think? Who can be the most exposed here? Obviously, the emergency doctor. But it takes time after exposure to develop the diseases. And that happened actually later. And the Times of India also reported our hospital. It was the picture of our hospital. Next slide.
Yes, Dr. Sourav.
Yeah. So we were actually fighting because we have to send the exposed staff or quarantine. At that time, that was the norm. And we were really struggling between the COVID-19 infection, fear, risk, and also to sustain our non-COVID-19 services. Next. So we tried to build isolation rooms, isolation facilities, and gradually the caseload get increased. And at that time, testing was also not available to us. It was very difficult to organize all those things. So we were just went on building the isolation facilities. Next slide. And yeah, it is now visible to me now. So we needed that leadership and the management support. And it was a fantastic teamwork of us with good vision and set goals. With motivation, we had the strategies and we faced the challenges. And we identified our strength, weaknesses, opportunities, and threats because it is very much important. Otherwise, we cannot know where from we are starting and where we are going. Our strength was our full-time dedicated staffs. Our hospital infection control committee was strong. We had the robust infection control practices. But what were our weaknesses? We had the novice or less skilled staffs because the skilled staffs were sent on quarantine and we could build many isolation facilities, but that was very limited compared to the loads coming. And also the neuro-intensive and neuroradiological procedures are very expensive and intensive procedures. So at every moment you can need a lot of PPEs. So that was our weaknesses. But we've identified our opportunities because we had our very much well-wishers. Many came as volunteers and we got municipality support also. But we had dreaded threats. I think this would be in all over India and world also, that the lockdown, the staffs cannot come to your workplace. And obviously the PPE exhaustion is an issue because the delivery of the supply is not so much planned according to the demand. The staffs falling sick or quarantined, and in neuro hospital particularly, the patient need actually at least 2 to 3 attendant per patient, because they have to take care for that. Otherwise, the neuro patient may not be doing well. So this attracts a large crowd. So the crowd control was very difficult, but it is a must thing. And these things, how we got the staffs getting exposed and infected also, mainly the nursing personnels and few doctors, including the neurosurgeons. So we actually very keen to observe that our infection control team was observing that we were not formal among ourselves, because whenever we were talking, as he is known, he is my friend, so we do not need mask, or we can have a common canteen, we can have talk over a cup of coffee and these things. And when the working hours are long, they need also refreshment and also to relieve the stress, so they were talking. But avoiding mask was a very disastrous thing. So we do not know the person I am just talking to is infected or incubating a disease. So this is the thing, if you don't know where you are going, you will probably end up somewhere else. So person was just having cup of coffee, talking and meeting, and we were just going on enlisting the cases, the exposed and the new identified positive cases. Now comes the second poll. What is the biggest challenge you faced in your hospital during this pandemic?
Yes, you can respond just below the screen. There is an option menu. Yeah, we are getting response now. What is the biggest challenge you faced in your hospital during this pandemic? Manpower shortage, PPE shortage, lack of reliable guidelines, lack of administrative support. And response is coming in all four options, which might be the real case, right? So so I'm closing the poll now. So now you will be able to see the response. 46.
Yeah, I can see the response. So majority have told that manpower shortage is a very much problem. I think these four problems will be there in every hospitals. But good thing is that lack of administrative support has not been complained. It is only 8% have responded that lack of administrative support, but administration has been very supportive in this pandemic. So that is a very good boon for us, actually, for all healthcare workers. Obviously, the manpower shortage will be the major problem. PP shortage is also reported by 22% of things. And despite good number of guidelines, and every second the new guidelines are coming, so lack of reliable guidelines is also an issue. And regarding this guideline preparation, so this time I made many guidelines, but this time what I felt, it is just like preparing a Durga Puja idol. So it was a hay idol that was built, on which we put the clay and then put the design, the colors. But it was never complete. We can see here the idol is never complete, because every moment we are just fighting with our guideline even and the practice. There is this balance. And the advisories are changing every day. So there was no fixed guideline. only a skeletal guideline was prepared, and every day we just went on dissecting it and to add on it and like that thing. So this was the skeletal guideline I will be sharing, that we targeted the general public also, and each visitor, including the vendors, patient relatives, and support staffs. That first thing, you do not panic, because psychological stress is very much in this pandemic. And avoid visiting the crowded places. Avoid touching anything that is frequently touched by everyone. Try alternative methods if essential, like opening the door with your feet, and avoid touching your face any time, because you do not know what your hand is harboring. And this was earlier, that if we were not strengthening the use of mask at that time from the very beginning, and we put it like that, you don't use mask if you are not trained in the way it should be used. Because nowadays also we can see the people are using just mask below their chin, or on exposing their nose, and even the pleats are also in opposite direction. So these things can spread or disease to the wearer and to the others also. So the mask has to be used the way it should be, and the hand should be washed frequently. And even if you catch the COVID-19, you please do not panic. You take physician's advice and follow the cough sneeze etiquette like a responsible Indian citizen, and restrict the urge to travel and postpone if not essential. And we encouraged our old patients to have the teleconsultation services instead of coming to the institute. For emergency or OPD personnel, we had a separate screening area in the OPD building and also in emergency. So the suspected patient has to be triaged over there. So a person will be sitting over there with PPE and the thermal gun and taking all the necessary histories. And the hand hygiene and respiratory hygiene are the essential preventive measures. And suspected patient should be given a medical mask if he or she is not having that. Instruct all patients to cover nose and mouth during coughing or sneezing with tissue or flexed elbow, because many a times we saw patients are just lowering the mask and having a cough. So this was not acceptable. And the hand hygiene has to be performed. 1 to 2 meter distance was at that time thought to be helpful because it's a droplet infection. And the alcohol-based hand rub, tissue, non-touch receptacles for disposal, face mask was supplied. Obviously, it was falling short of demand, but we were managing somehow. And the team of dedicated residents manning the area were done, and they were ensuring the minimum waiting time before admission, because otherwise that would spread infection much more. So we were having, these were treated like a VIP. Whenever the person with symptomatic acute respiratory illness will come, they would given the minimum waiting time and put to the isolation facility if required. And the healthcare worker has to use the N95 respirator during work in designated areas, have to use personal protective equipment, and donning and doffing has to be there in a designated space. The equipment, if needs, we had some dedicated equipment, but for the isolation facilities. But if the equipment needs to be shared, it has to be disinfected properly. And similar to general public, they had to refrain from touching their eyes, nose, and mouth with potentially contaminated hands, and avoid contaminating environmental surfaces like door handles and light switches. And when providing care in close contact, they have to use the goggles. For the inpatients, regarding other suspected and other patients, we have to use the predetermined transport route to minimize exposure for staff and patients and visitor. So our maintenance people, the engineering people did a lot help in this to determine our transport routes so that we can reach easily, and the staff entry and the patient transport are completely separated. It was very difficult task to do actually, but we somehow managed this. And visitor access to patient was restricted because we cannot restrict the attendant, but we had to restrict the visitor for the inpatients. So we revised our visitor policy from 2 person to 1 person. And the dedicated diagnostic and therapeutic devices has to be provided, including the portable ultrasonography, electrocardiography, mechanical ventilation, cardiorespiratory monitoring equipment. And for requirement of the procedures like computed tomography scan, CT scan, or operative procedures, which require a planning and a sustainable time, we just advise for doing it out of routine working hours, so that minimum time will be in transport and in waiting. The hospital personnel involved in shifting and managing the patient outside the designated area should follow all the standard precautions. The specimens collected for laboratory investigation should be regarded as potentially infectious and has to be labeled clearly as suspected COVID-19, because this would also help in disposing as COVID-19 biomedical waste from the laboratory side also. And we defined our aerosol generating procedures, and we had the guideline for that also, that a person will be preferably doing it in a single room and should use PPE, long sleeve non-permeable gowns, eye protection, and N95 respirators. But obviously, we were falling short because we cannot check all the boxes, because person to person variation is there, and our supply cannot meet the demand. So we were actually meeting every morning and evening. Our all teams, administration, management, maintenance, infection control, and doctors, nurses, one representative from all, to have a meeting and to tell what was our findings in that day and what is our goal for the next day or the next coming days. So this was very important, because otherwise resources will just get depleted and we will be just failing. So it was very important. The meeting we have decided next day's goals, and we identified who will be doing what, the roles, and how the team members should interact. That is, sound internal relationship has to be there, so that we have to tell them personally, and the effective internal working process has to be continued. Otherwise, if any person is doing out of the track, the whole team is actually in danger. And we put stress on the 3 pillars actually: the hand hygiene, PPE, and environmental cleaning. The hand hygiene has to be done with the alcohol-based hand rub or soap and water for at least 20 seconds. And if hands are visibly soiled, the soap and water has to be used before returning to the alcohol-based hand rub. The PPE has to wear to avoid direct contact with patient's body fluids, and designated areas were marked for donning and doffing of the PPE, excepting the N95 mask, where we were doing the rationing and reusing it, extending use. And the gloves, if torn or heavily contaminated, it has to be changed. Remove and discard gloves when leaving the patient room or care areas, and immediately have to perform the hand hygiene. Similarly, the non-permeable gown has to change if it becomes soiled. And for respiratory protection, 3-layered medical mask has to be worn by the patients and disposable N95 respirator to be worn by the healthcare providers. However, regarding our poor supply and in compared to the demand, we had to extend use of the N95 respirators. The environmental infection control is very much important, and I told in the isolation facilities there was dedicated medical equipment or single-use disposable equipments, and the shared things has to be cleaned and disinfected as per our routine disinfection protocol, because COVID-19 is susceptible to all routine disinfection protocol we are doing. The alcohol, 70% alcohol, and the quaternary ammonium compounds. And environmental cleaning, we have the sodium hypochlorite solution, mainly for the floorings, and disinfection, prevention of the needle stick or sharp injury as universal precautions. Safe waste management has to be there, and reinforcing the proper use of PPE, because we were observing who is doing what uses of this PPE, whether there is any abuse or not, whether any improper use or not. So the reinforcing the knowledge and practical knowledge particularly is very important. We found it very helpful. So here is a glimpse of to what extent we were doing our surface disinfection. I was also in some of the pictures, because we were doing everything. Our manpower shortage was just like that. So everyone was cleaning actually his areas. And when a person is cleaning and you are taking a picture, and probably he is far more becomes responsible. And we can see they are using fogger machines, and after fogging we were just wiping it so that proper surface decontamination is there. And it started from everywhere, from patient transfer trolleys to the door knob, and including the signage also. But what was consistently followed is that if you follow a consistent cleaning path, the outcome is better. So we designed how area can be cleaned in a consistent way. So that was our achievement. And here we can see how the patients are being transferred on a wheelchair. The person accompanying wears the PPE, gloves, N95, and a visor along with a head cap. The visor we advise for all persons. And we can see here the thermal gun checking is being done for all persons coming to the hospitals. And this is the sitting arrangement. This was very unique to us, because our administration and quality team also devised all these things. For the neuro patient, we actually required 2 chairs together, because I told the neuro patient needs 1 attendant at least. So if you put 1 chair separated, 2 chairs separated, so they will just pull that chair together and will sit. So better to have 2 chairs together and make a distance, and that's for the 1 patient and his relative. And here you can see our spacesuit clad COVID warriors. Actually, this from the first picture is from our operation theater. They were so much enthusiastic, wearing all those things and doing all those marvelous jobs. The I2 is the next pictures. They were the spacesuit kind of thing, the full PPE and coverall, and performed brilliantly. And in the corner, we can see our outpatient department, where the open window is there so that the air can move from the consultant to the patient. and patient is sitting at a distance. So the social distancing is also being maintained, and the nurse is wearing the mask and gloves. So here comes the third poll question. COVID-19 waste management requires no added or special step than usual biomedical waste. True or false?
Yes, poll is active now. We are getting response. Interesting, getting both responses. Good. So maybe another 10 seconds to respond. COVID-19 waste management require no added or special step than usual biomedical waste, and looks divided opinion.
Yes.
So we are closing the poll now. 72% said false, 27% said yes.
So although this COVID-19 virus is actually amenable to usual steps, but the guidelines have told us the rules that we have to add special steps. So what are the steps? So ultimately there was confusion regarding the COVID-19 biomedical waste disposal also, but finally on the last revision 4 dated 21st of July, they have made clear that we will be following that biomedical waste management rule of 2016 and 2018 amendment with certain modification for the COVID, that one separate record of waste generated from COVID-19 isolation wards should be maintained separately, and that data should go. And opening or operation of COVID-19 isolation wards and sample collection center should be reported to State Pollution Control Board. And dedicated trolleys has to be there with COVID-19 label so that they cannot be mixed with other non-COVID-19 waste. And this collected biomedical waste should be stored separately in a temporary storage room prior to handing over to the authorized staff, or it can be handed directly also. But the record has to be there. And dedicated sanitation workers should be deputed separately for handling biomedical waste and general solid waste for COVID-19 wards. And general waste not having contamination should be disposed of as solid waste management rules. And what more required is that 2 bags are required for the COVID-19 waste disposal so that it can minimize the risk of infection to the waste handlers. So 2 bags should be there, yellow and red, and the inner and outer surface of the container, bins, trolleys, and the bigger container should be disinfected with 1% sodium hypochlorite. So that was the added steps. But this time, because it was very predominant in our day-to-day life also, so in quarantine centers, that rule was applicable. So from where general solid waste should be handed over to the waste collector identified the urban local bodies. These urban local bodies played a very important role in mitigating the risk from the waste management, and the biomedical waste and the general solid waste should not be mixed together. And the rule provision for the urban local bodies so that they could supply the yellow colored bags to the quarantine centers and even to the household also, so that they can be taken care of and disposed of accordingly. We can see here for the people who are taking care of the quarantine home or home care, they also generate biomedical waste. So they can have 3 ways. They can either hand over the yellow bags containing the biomedical waste to the authorized waste collector at doorsteps. The urban local bodies will be authorizing in that, or the deposit the biomedical waste in YOLO bags at designated deposition centers established by the urban local bodies. Or if they are going to the hospitals, they can dispose over there also. And our West Bengal is doing a fabulous job actually. So we are actually putting the vital parameters of all the patients in an electronic database. It is a COVID patient management system, and early warning signs we are also monitoring that, we are also putting it. And thankfully to all our dedicated staffs, we are doing 100% transparency and 100% compliant till date. And with all those things, all the dedications and works of the healthcare workers, the INK has been continuously performing the neurosurgical procedures. During the pandemic, we operated 3 COVID-19 patients who had bleeding, intracerebral bleeding, and it was very tough task for us, but we handled all those risks. Now regarding some things about this mask. So how much the mask protect us? So the medical mask for that fit test is not needed, and mainly prevent the droplet infections. The filter performance is variable with inward leakage variable, and it is very much important that the person wearing it, the behavior of the person, he shouldn't touch the outer surface or the mask unnecessarily. And regarding the filtering face piece, the FFP2 is akin to N95 mask. We can see the filter performance is 95%, but inward leakage rate is always there with all those filtering face pieces, that is 8%, and for N99 it is less than 2%. The PAPRs, elastomeric respirators, are better. We had used PAPR for the OT personnels. And this is a very challenging thing. Your N95 mask is actually not a sieve. It is a very complex thing by which it is protecting us. So we had very much trouble to make the administration understand this. If a person is given one N95, why it is required to, the person has requiring another N95. So it was our duty that N95 is not a sieve, because the filtration mechanism works on 4 principles actually. The larger droplets will have inertial impaction. More than 1 micron size particle will get inertially impacted over this N95 mask, which is a fibrous mesh of non-woven fibers. And in diffusion will occur for the very small particles less than 0.1 micron. They will get absorbed to the fibers. And interception and electrostatic attraction are the things by which the both small and large infectious droplet will get filtered. And N95 performance testing is very much required, but in this time where we had no access to N95 even, we had to extend the use, and obviously we had to compromise on quality also, because we could not check it. It was not available. But ideally that has to be checked, and particularly after 5 uses, it has to be tested for the fit test and the fit tests. And in the pandemic has shown us many new things, and these new things is that started in US, that person feels it is his right to not to wear the mask, as it is hampering his independence. And the same wave also came to the India, and people on 15 August was demanding freedom from mask. but don't fall prey to this trap. Why I will say, there was a study. It was in a Duke University of US. So it was a very low cost study by which they had control and test population who were talking, and they measured the scattering of the droplet through the laser. And by their study, they concluded that the N95 mask was obviously the best, but surgical mask did a very good job. And the cotton mask also, we can see here, was doing good things in preventing the droplet to come into outside. But the fashionable bandanas and the fleece were not doing the things it should be. Rather, it was very dangerous, because what were these fleece were doing? Because nowadays we are having people to just putting a scarf on his nose and moving here and there, behaving like he is wearing a mask. This fleece, actually what it does, it breaks the bigger droplets into very smaller droplets. So actually the droplet rate gets increased if we use this fleece. And we can see in the next figure, the scatter, the droplet rate. If person is not wearing the mask, it is in green color. We can see it is giving lot variable droplet count. If a person wears a cotton bandana, red, we can see the dispersion and the droplet count gets decreased, but it is still alarming. And even if a person wears a cotton mask, it is much less in number, the droplets. And if the droplets are less in number, so obviously the infectious particle emission will be indirectly less in number. And the surgical mask, obviously better than the cotton mask. And in this scale, they are actually not visible because they were doing fabulous job. So here comes the last poll actually. Healthcare workers are immune to infectious diseases due to subclinical and continuous exposure. What do you think, true or false?
Interesting. Healthcare workers are immune to infectious disease due to subclinical and continuous exposure. We are getting response for true as well as false. Next 10 seconds, please respond. We are going to close the poll now. Okay, we are closing the poll now, and the result is 78% says false, 21% roughly says true.
Yes. So if we are immune, then probably we not be waiting for the vaccine to come, and probably we are not wearing the PPEs. So I think if we are already immune, then there was no need to do this webinar on occupational safety. But yes, we do have some certain immunity to common infections. And that I told, one emergency nurse told me that she has exposure to every diseases. So the immunity is like a workhorse. But remember, your workhorse is also a thing that should not get fatigued. If you get continuous exposures, so there could be energy and your immune system could be failing. So that is one thing has to be said. So it is actually the myth that healthcare workers are immune. But despite the good availability of a good vaccine against hepatitis B, you can see there are certain 30% or around that can be non-immune to the hepatitis B, because our immune response is not equal for all. and the healthcare associated infections. We are much bothered about the patients, but healthcare workers also working in that environment and can get healthcare associated infections. In our hospital, we actually screen all the patients and also the healthcare workers for the healthcare associated infection, because their immunity is also important, and they are also important case for healthcare acquired infections. And there is a very important, interesting study in Nature Research, which studies about the immunological effects of shift work in healthcare workers. They have compared the shift workers with non-shift workers. Shift working including the night shifts also, where they saw that less educated persons are most employed in the shift work. And as a result, the shift work, their immunity gets a bit lessened than the non-shift workers. Particularly in this pandemic, we are bound to do this shift work now because of shortage in manpower. So we are, the healthcare workers are actually falling prey to the immunological effects by which they are getting the infections, and things are like that. So we can see here now, as per the, there is no official database, but throughout India, around 282 doctors and nurses have been uh, dead due to the COVID-19, and lots have been infected. So we really need to work out whether this shift work has some effect into this. Lastly, the International Labour Organization has, in association with the World Health Organization, issued an occupational safety and health in public health emergencies. It's a very good manual to follow for the healthcare workers like us and also the responders. It has beautifully delineates whatever can be done in public health emergencies, including a pandemic. So this is a very good document. And I was thinking there was a lot study material, lots of webinars going on through the world on this COVID-19. But what is unique that we are having this webinar by the IFCAI, Hyderabad University and SANMED? Because this was the reason. The 60% prefer to watch video rather than read a post. So that is the reason. If it was a post, probably this person will not read it, but 60% have preferred to watch the video. And most importantly, 95% of messages are retained when watched, but compared to 10% when read. So I think we should thank this webinar and the organizer, including the SANMED, for this, because delivering a webinar also, I could retain the 95% of messages that I have given. And lastly, we the healthcare workers are doing fabulous job, and we have to remember that the credit belongs to the man who is actually in the arena, whose face is marred with dust and sweat, who strives valiantly, who errs and may fall again and again, because there is no effort without error or shortcoming. So to get our dedication and all those things will certainly have us keep us out of this pandemic. And to boost our healthcare workers, our INK administration has given certain prizes to the warriors also. And since we were practicing the Namaskar drive, we were not doing the handshakes. So it was probably somewhat easy for us to adjust to this new normal. Thank you.
Thank you, Dr. Sourav, for a very interesting presentation as usual. Quite enlightening, and we see that most of the hospitals where we have a dedicated infection preventionist with experience, the systems and processes and the protocols are followed, um, like on a global scale. It again comes back to the same point that if the hospitals, the healthcare institutions, either they are private or public, if they are going to have the right kind of manpower, uh, if they build the right kind of capacity of human resources, then definitely things are going to be much more smooth and also much more professional, and it would not only help the patients but also would help the healthcare workers to remain safe and provide more care and to the large number of people, whoever get affected by the emergencies like the COVID-19. Thank you very much, Dr. Saurav, for taking your time and presenting a very, very interesting narrative of all your experiences for last 6 months. Thank you very much. I think we have a couple of minutes of time. Maybe we could very quickly answer some of the questions. One question coming from Dr. Ketaki. Is there any guideline which mentions about how many days a healthcare worker should be refrained from work if healthcare worker comes COVID positive but asymptomatic?
Present guidelines tells it's 7 days, but it can vary from state to state. So it is better to consult your state guidelines if available.
Absolutely. The second question from Kranti Putta. Can we use green mask for use as present situation in hospital cannot afford? Means basically, what he's asking is their
The cloth
hospital
one.
is unable to afford the right kind of mask. Can they wear green mask? I don't know what is green mask. Maybe it is a cloth mask.
Green mask can be cotton mask that usually seen in government hospitals, or it can be a single ply surgical mask. Both are green. So in both the cases, they are suboptimal definitely. But if you are not getting supply, so you have to use that. But along with that, you have to maintain the social distancing as far as practical, and the hand hygiene very importantly.
Absolutely. I think Dr. Saurav has actually presented all those types of masks. In the previous sessions also, we talked about them. Definitely, you should be mindful that when you are dealing with hazard, right? Because when we are working in healthcare institutions, we are exposed to hazard. So we definitely need to be, in line with the current guidelines. The current guidelines very clearly say that cloth masks cannot be sufficient in healthcare institutions, especially if we are dealing with COVID-19 suspects or patients. Okay, so this had to be kept really, really, in mind, and not risk your life. That is the whole purpose of actually, bringing this topic to you. One more maybe question. It is again related to the masks only. Is it advisable to reuse N95 masks? Uh, isn't it using N95 in absence of any aerosol generating procedure a misuse and wastage? That is what is the question. I don't know. There is something called as first last. I can't make a name out of it.
So regarding N95, we are now facing issue of supply. There is a gross disbalance between supply and demand. So I would suggest the audience to refer to the CDC guideline regarding this. They have advised three strategies for this N95. One is conventional, where after one N95 mask only for the 8-hour shift, then it has to be discarded totally. Second is the contingency, when you have the expected shortage. And third is the crisis, when you have known shortage. So presently, if you are having in contingency or expected shortage, you have to extend the use. Like what we were using it, after 1 day use, the healthcare worker is putting it in a paper envelope for 5 days, and after next day he is using another fresh N95 mask, and by this time this cycle goes on, and these 5 days actually will diminish the viral count if it is there. And for the reuse, we were using the UV GI system actually. We do not know how much it is effective, but it is definitely recommended by the CDC, along with the hydrogen peroxide vapor, and they have mentioned moist heat also. We had access to the UVGI system where the 15 minutes exposure time was to be given, but this is a very technology dependent thing. We have to take advice from the engineers and technical experts. So the wearer has to mention with permanent marker the name, the date of first use, and the number of recycles being done. Otherwise, it would get messed up. So with this permanent marker, they written this, and one person would put it in the room, and after 15 minutes from start to stop button, it has to be removed and put in fresh paper envelopes to be supplied again. So that can be done. And regarding when to use this contingency plan or this crisis plan, the CDC has given us a Microsoft Excel based calculator when you can calculate your PPE burn rate. This can for the gloves, this can be for the mask, and even your face shield also. That is brilliantly, and there has probably also a mobile app also on that. We had used the Excel app for experimental purpose that can give rise to the tell you the burn rate per day, so you can be prepared.
Sure. Thank you, Dr. Sourav. I think, we have almost reached 1.5 hours. The people are probably scheduled to take up something else. I really thank you and look forward to yet another session. I'm sure, all our colleagues from all over the world, they are going to come with their suggestions on what had to be the next session, because all the sessions which are being organized by Infection Control Academy along with SunMed are those sessions which are of practical use to the infection preventionists and other healthcare workers who are currently dealing with the pandemic, and also otherwise also generally improving the patient safety. So please come back with your suggestions regarding the topic for next series. We are going to announce it very, very soon, probably in a week or two, and then we will take up yet another interesting journey and also interesting learning from each other. Thank you, Dr. Sourav. We will catch up again on that. Just to request you, some of those points what you have talked about CDC, if you could kindly post them in YouTube, below
Okay.
below your presentation, some of those links which are related to the Excel what you have mentioned, other things that would be quite useful for the people to access them and further evolve in terms of their knowledge and also the experience. Thank you very much once again, Mr. Pranav. Over to you.
Yeah, that's thank you very much, Dr. Sourav. Very interesting topic you have presented in a very nice way, lucid way, and holding people more than 90 people, 100 people together for 1.5 hours is a big task you have done. I would like to thank the people also here, the participants. More than 106 people already submitted their suggestions for the future programs to us, which I got already from you. All of you will get the certificate by tomorrow, today and tomorrow, these 2 days, all first 100 people at least. Thank you very much. Thanks to SunMed. I think what Dr. Sourav said, there is still need for more PPE as well as the mask. There is a N95 mask deficit. SunMed should consider. I think Ramdas is here, so you should consider to launch that which is needed for infection control professionals. That would be great service in addition to education. Dr. Ramdas?
Pranav, we are on the way, and I think in a week's time we'll announce it. I think we are almost there. I think
You should
we are coming out
make it
with
a high
95 mask
quality.
and
You should make it very high quality and affordable, so that
absolutely.
the questions which were raised about non-availability, that issue is taken care
Yeah, I was
of.
observing that. Yeah.
Thank
We'll do
you.
our best. I think we are coming out with plenty of stocks. Thank you.
Thank you.
Thank you, Ramdas. Thank you very much. Thank you all the previous speakers as well. And we are closing the session now. Thank you very much.